A safe delivery does not mean the mission is over. The postpartum body is like a rocket after landing. Fuel supplies shift, fluid drains, and systems reset. As the nurse, you are mission control. And when the alarms sound, when a patient's heart rate spikes and blood pressure drops, you have to respond. This dashboard represents a specific clinical judgment loop. It is a cycle where you recognize a change, connect the data, prioritize the threat, plan your response, take action, and evaluate the result. On paper, this looks like a deliberate, step-by-step checklist. In a true clinical emergency, these steps blur together. Assessment and intervention happen almost simultaneously. In a crisis, the challenge isn't just knowing the facts, it's processing them while the dashboard is flashing red. To see how that systematic approach works in real time, let's look at the first mission report. Let's apply the loop to patient A. She is 1 hour postpartum. She saturates a pad in 12 minutes, and her fundus is boggy and displaced to the right. Look past the bleeding to find the source. A boggy, displaced uterus points to the first T of hemorrhage, tone, specifically uterine atony. For immediate action, massage the fundus to stimulate contraction and empty the bladder, preventing the uterus from clamping down. Now let's pivot to patient B. She presents with a continuous bright red trickle of blood, but when you palpate her abdomen, her fundus is rock hard and perfectly midline. This highlights a critical contrast. A firm uterus with ongoing bleeding means you are dealing with the second T, trauma, typically a cervical or vaginal laceration. If she has severe perineal pressure with no visible bleeding, suspect a concealed hematoma. A firm uterus does not rule out hemorrhage, it simply changes the cause. You cannot massage a laceration away. Let's escalate the complexity with patient C. She delivered twins after a prolonged oxytocin-induced labor. Her uterus is boggy, and her heart rate is climbing. Here is the underlying medical history that complicates her treatment. Patient C has asthma and preeclampsia. In this moment, you must act on the tachycardia and rapid pad saturation. Do not wait for the hemoglobin and hematocrit labs to drop. Postpartum hemodilution makes early lab values unreliable during an active bleed. This brings us to the phase of generating solutions. Based on her specific history, which standard hemorrhage medications are safe and which are harmful? Pause the video and write your answer. Memorizing a list of uterotonics is a flawed strategy. If you fail to cross-reference those drugs against maternal comorbidities, your treatment becomes a massive liability. Here is the breakdown. Methergine is strictly contraindicated because of her preeclampsia and hypertension risk. Hemabate is crossed off the list because of her asthma. The correct pharmacological choice to safely treat patient C's uterine atony is oxytocin. Once the medication is administered, we evaluate the outcome. Treatment is only considered successful when the fundus becomes firm, visible bleeding decreases, and her vital signs stabilize. If they do not, you escalate. This matrix details the diagnostic rules. Tone means a boggy uterus. Trauma means a firm uterus with bleeding or pressure. Tissue points to a retained placenta. And thrombin means oozing from IV sites and a failure to clot. Mastering postpartum emergencies requires pairing these 4 T's to find the source of the bleeding and drive them through the clinical judgment loop to systematically secure maternal stability.